If you're a pharmaceutical company and you're trying to sell testosterone to an NHS GP, you're not going to say to them, it should be injected a few times a week for optimal patient results. What they're going to try and do is say, you only have to get the patient in once every 3 to 4 weeks, inject them with this, and they'll feel brilliant. There is an element of trying to sell it to the doctor as well from the pharmaceutical companies, and I'm sure that has an impact.
Yeah, absolutely.
Hello everybody and welcome to another video from Optimel. Today we're going to be looking at injection frequencies, which is quite a hot topic in the TRT world. The first thing we're going to talk about is what pharmaceutical companies actually recommend in terms of injection frequencies for their products, because often it's the kind of thing that doctors will rely upon when they are deciding what injection frequency to give to their patients, because they assume that the pharmaceutical company has researched it and decided on the best possible injection frequency for the patient to have good results. I certainly don't think that is the case in a lot of these medications. A classic example is testosterone, 250 milligram in a 1 milliliter ampule. The recommendation on the patient information leaflet is 1 injection every 3 weeks and 2 to 4 weeks for trans people who are transitioning from female to male. The issue with that is, and their own study showed, after a few days, the testosterone level on average was 70 nanomoles per litre, which is much higher than you would really want in somebody who you're just replacing their testosterone levels. By the end of those 3 weeks, it's down to about 8 nanomoles per litre, which is considered a low testosterone level and will cause symptoms. It's just a terrible way of providing the medication. Another example is Ananthate. I believe it's a similar kind of story. 1 injection, 250 milligrams every 2 weeks. And I can't see where they have got that from.
I think it's typically because they consider within range testosterone levels as normal. So as long as after the 2 weeks the levels are somewhere within the reference range, irrespective of how low, the patient is still considered eugonadal, and administration every 2 weeks, where it's often kept inside the doctor's office so the patient doesn't have access to the testosterone, is deemed to be infrequent enough so that it's not a hassle to the doctor, but frequent enough to keep them within the reference range. This primarily represents the issue with the way in which doctors who aren't informed on this area treat patients, in that we know clinically patients with levels within the range but towards the bottom, particularly if they're below the BSSMs less than 12 nanomole per litre total testosterone, will still experience symptoms. So you're putting men on testosterone replacement therapy on these awful protocols. A lot of the time, or the vast majority of the time, not only do their symptoms not improve, they develop numerous different side effects like elevated hematocrit, elevated estrogen, and they just feel like they're on a roller coaster because they are, but because when they have their serum testosterone levels checked at the end of that 2 week, their levels are just about within range. They're told that it's nothing to do with testosterone and they must just be depressed or anxious, or insert any other relatively non-specific psychiatric disorder dismissed symptoms that probably are related to a poor TRT protocol.
Yeah, exactly. And I think this is probably the reason why a lot of endocrinologists in particular think that testosterone replacement therapy isn't effective. And it adds to the reasons why it's not prescribed as frequently as it should be. It's a big issue. Hopefully it's something that's improving a little bit in the UK now in terms of how people see it. I know with Optimel, I would say the average injection frequency is 2 to 3 times a week. It's usually something that the patient can decide upon themselves. You know, if they want to do a daily injection of testosterone, that's fine up to a point. You can't really request your dose, as in, I want to have a testosterone level of 100 nanomoles per litre. The doctor's obviously not going to go for that. The doctor, most of the time, the doctors are happy for the patient to have a much more frequent injection protocol. Or if they want, they can have a less frequent injection protocol. It really does depend on the convenience factor combined with the results that a patient feels, but also that we see in the lab reports.
Yeah, I think eye doctors tend to push patients towards injecting as frequently as they can without it becoming a hindrance on their life. Some people, particularly young guys that do a lot of research, learning about TRT in general, and they find it interesting. A lot of them want to be on the most optimal, per se, protocol, so they will do the daily injections of cypionate and HCG. For the vast majority of men, and I did daily injections for about 2 years in total, it's too inconvenient, and the difference between going from, say, every other day or even twice a week or 3 3 times a week to every other day and then to daily, the benefits that you get become smaller and smaller and smaller, that the cost benefit ratio just really isn't worth it for a lot of men, and it does become rather mundane after a while.
Yeah, I mean, that's my personal experience of it as well, and I think that's what a lot of our patients see. I've seen a lot of patients who've said, I want to do daily injections because that's going to make me feel better and I'm not going to have this issue or that issue, and they try it and it doesn't make any difference. They quite quickly go back to 3 times a week, which for me personally is the best cost benefit that I've found.
If you look at the half-life of cypionate and Ananthate, which is typically what the vast majority of our patients are on, and it's what our doctors do like to prescribe, the half-life means that on 3 times per week you're getting pretty stable levels. The difference in stability between 3 days a week and daily is significant, but it's not, again, to the point where it's going to completely change the outcomes of treatment for every single patient. So some people might derive benefit from that. In our doctor's experience, the vast majority don't notice too much of a difference, might notice a little bit. But again, the drawbacks of doing that, and it does become very, very tiresome after 2-3 years. When you first start, it's a bit of novelty. Injecting every day, sometimes it can be even quite fun at the start because it's something new and you do feel like you're doing the most optimal way, but after 2 or 3 years, it just doesn't feel worth it anymore, to say.
Yeah, I mean, I did it for a couple of weeks, but I'd been injecting for a few years before then, rather than starting with that protocol. But I can understand why for some men, it may help them to control their estrogen levels. Perhaps you have 3 or 4 nanomoles per litre difference in peak, or fluctuation, I should say, in levels between if you're doing 3 times a week versus daily. Then that might cause more of an increase in estrogen levels, for example, that might have a certain impact on you, in which case, fine, daily injections if you want to.
One of the main benefits of doing daily injections that a lot of American doctors say this, is replicating natural physiology. There's nothing inherently natural about injecting esterified testosterone daily. Just the fact that the act of injecting testosterone itself isn't inherently natural, and there's nothing wrong with that. It doesn't mean that it's bad or that it's inferior, but it also means that you can't use something being replicating natural physiology as a benefit. But also, serum levels on daily cypionate are going to be extraordinarily stable. And then when you look at the endogenous production of testosterone, they can be up to a 40% swing from morning to nighttime, with the highest in the morning, lowest at the night. And that's, the younger a man is, the more pronounced that diurnal change is. And older men with lower levels tend to lose that diurnal production. They have much more of a flatline low level across the whole day. So again, I think there's nothing inherently harmful about having fluctuations in serum levels within reason. So the idea of keeping your levels as stable as possible, obviously you don't want to put people on a roller coaster of every 2 weeks like we said, but again, to a point, the actual benefit you're deriving from going more and more frequent with regards to reducing fluctuations is still minute at best.
Well, exactly. I think if you really, really wanted to replicate a natural production or secretion of testosterone levels, you would need to have a pump, and you certainly wouldn't use something like testosterone cypionate. You would use testosterone that's released into the bloodstream as much as possible in a way that testosterone is released into your bloodstream without an ester attached. And then you'd have to work out how to release it in a way throughout the day that's similar to how the body releases it, which you could probably do, actually.
Yeah.
It's the same as an insulin pump in diabetics. That might be something that's produced in the future, but the idea that you should inject an ester with a half-life of 4.5-5 days daily because that's replicating a daily release of testosterone which doesn't have an ester like that, which has got a half-life of a few hours, it's not quite the same thing at all.
Just to touch upon the kind of device that you suggested there, that could easily be created, but predominantly one of the main reasons that it likely isn't is, would it actually promote improvements to clinical outcomes? Would patients actually feel better? And if they would it be worth the increase in cost because that would be patented and it would be very expensive? Would it be worth the hassle versus if people just feel good injecting 3 times a week, sometimes more? If it doesn't actually make people feel all that much better, then it's just, again, it's similar to daily injections. It's just not really worth the hassle.
Absolutely. I don't think it would be worth it for the supposed benefits compared to an ester which is releasing over a certain period of time and really isn't causing huge spikes or fluctuations in levels if you're doing it 3 times a week. I think the next advance will be probably some type of pen where you can inject small amounts of something like cypionate, pre-select, I'm going to do 0.2 mils, and then inject straight into your subcutaneous with that pen, switch out the needle. Exactly the same as a diabetic would do with something like insulin, but with something like cypionate, which will just be a very easy, quick way of doing things rather than having to draw up.
I'm not completely familiar with the brand name of the product, but there is actually a relatively new auto-injected product on the market in America specifically, and we've had a couple of chaps who've moved to the UK from America and transferred over to us who were on that before, and it actually comes in a 75 milligram auto-injected pen that you just stab into the top of your thigh and it does it for you. And I think the guidelines for that start out at 75 milligram once per week. That's the recommended starting dose, which again, for the vast majority of people, at least a day or two before they do their next injection, is probably going to leave them the same, if not worse off as they were before treatment with regards to the actual serum testosterone level that's achieved.
Yeah, exactly. It'd be interesting to see that pen, the auto-injector. I presume you can adjust the dose on that.
You can get different pens in different dosages, but you can't adjust the same dose from the same pen. It's just a one-time use.
Oh, so it's like a one-shot injection.
And you throw it away after it's
right.
Been injected.
That's not so good. There's not really much benefit in that. Then it's just a bit more convenient, isn't it? And potentially less risk of infection for people who don't know what they're doing.
I think the take-home message there should be similar to what our doctors suggest. Inject as frequently as possible without it becoming a hindrance. If you can do daily, perfect. It probably will produce some sort of benefit for you. If you can't do daily, every other day or 3 times a week will be absolutely fine for the vast majority of men. Weekly, now you're getting to the point where you probably are going to have some issues, and you can't present weekly injections as an optimal protocol even if a patient feels well. It is going to be somewhat inefficient regardless, and then every 2 weeks is just completely non-viable.
Yeah, the only thing I'd add to that is, for some reason, if you had to do weekly, you would probably want to go for testosterone, actually, I would say, just because it's got that longer ester in there. It's certainly not optimal. It would be better than doing cypionate or Ananthate once weekly. That's something that I used to do, and it worked pretty well, to be honest, but you do still have like a peak at the start of the week. It's not optimal by any stretch of the imagination, but it would be better than something like cypionate or Ananthate once a week, I think, which is actually quite a common protocol in America, I believe, once weekly injection of Ananthate or cypionate. So what about creams or topical solutions, Tom, then?
Creams are absolutely an option. Transdermal products generally get quite a bad rap because people associate them with low concentration alcohol-based gels like Testogel, Testim, Androgel. Some people do get on okay with those if you have quite good absorption and they actually do get your serum testosterone levels within a range that does produce symptom resolution, then obviously it is going to work with you. Does that occur for most men? No, they don't see a huge rise in serum testosterone levels. The testosterone is unesterified and the prescribing guidelines suggest for Testogel, for example, 50 milligram once per day. It's also quite common that when you test their levels at trough 24 hours after they applied their last dose but before they apply their next one, their serum testosterone levels are sometimes extremely low. We see some people come in because they've been shut down from the testosterone use. They're not producing their own testosterone anymore, but the Testogel's left their system. You can have levels of 3, 4, 5 nanomole per litre testosterone before you apply your next dose. So theoretically, it needs to be applied twice per day because the gels are, 1, expensive because they're patented, and 2, they're low concentration, so you have to apply a lot of the gel itself. Doing that twice a day isn't similar to daily injections. It just becomes too much of a hassle to apply all this gel that's alcohol based, so sometimes it can burn after a while too. Twice a day, every single day for the rest of your life, roughly the same time each day. Whereas with creams, because you can compound them at much higher concentrations, for example, Testogel is 50 milligram per 5 gram, whereas you can compound gels all the way up to 200 milligram testosterone per 1 gram of gel. You need much less creams. It's more convenient with that respect. You also, the base that the testosterone is suspended in has a greater absorption too. Finally, because it is at a high concentration, you can achieve much higher serum testosterone levels than you can with a gel, and it does produce that symptom resolution more. And because it doesn't have alcohol, you can also apply it transscrotally. Because there's a higher 5-alpha reductase content in scrotal skin, it does tend to produce higher DHT levels than injections. DHT is typically what's associated with increased sex drive and things like that in men, although it is rightly or wrongly associated with other issues like problems with the prostate. Discussion for another video. Creams can be very effective. However, again, because they've got the short half-life, they do need to be applied twice per day at a minimum. You don't want to be putting yourself on that huge roller coaster. Twice per day application does produce relatively stable serum levels. You do get some fluctuation, but again, natural testosterone production isn't inherently stable. It can swing wildly, so the cream is completely viable and effective treatment modality if a patient did want to go down the transdermal route.
What's quite interesting is, I was speaking to somebody yesterday, I don't think this study is published yet. I need to have a look to see if and when it's published so we can talk about it. This doctor yesterday was telling me that there's a new study that's being done in Europe. They were looking at the different modalities, so I'm imagining all of them would have been pharmaceutical products: Testogel, Testim, Cypionate, Ananthate, Sustanon, maybe Nebido. And they were basically looking at them and saying which of these has the best results for the patient, presumably looking looking at lab results, negative side effects as well. Apparently, according to this doctor, the study's results showed that the most effective testosterone product for the patient was the Testogel. I was immediately very skeptical of this because our experience of Testogel is that it's not very good and patients don't get on very well with it, particularly after the first month or two, for the reasons we've just spoken about. It'll be very interesting to see the study. We don't know what it says yet or what their methods were. It sounds like it was quite a large study, and it's a bit disappointing, to be honest, because I suspect what has happened is they have relied on the pharmaceutical companies' recommended doses and recommended injection protocols, which means they've been giving testosterone once every 3 weeks and Ananthate every 250 milligram every 2 weeks, and it's caused massive spikes in estrogen followed by a massive drop in testosterone levels, and then the patient has terrible results. And as a result of it, the only ones who would have had any decent results will be the Testogel guys, and they'll probably come to a conclusion basically saying that TRT isn't actually that effective at all, because if you look at these kind of protocols, it's not going to look very effective, is it?
Yeah, and that would be the expected results. We would expect that people on Testogel would feel good compared to 250 milligram of Ananthate every 2 weeks, but that doesn't inherently mean that Ananthate as an intervention is ineffective. It means the way in which it's being implemented is ineffective, and that's a very key distinction. That it's the problem with scientific research is nuances like that. When you're trying to obtain the kind of results that they're looking for, you can't have one group on daily injections of Ananthate, one group on twice a week, one on every 2 weeks, because there are just so many confounding variables that it wouldn't work.
And it's concerning because the end result of this is it will influence decisions on guidelines and recommendations. So you're going to end up with doctors across Europe saying, well, actually, the research shows that Testogel is the most effective for patients. And then they'll stop recommending any kind of injectable.
Yeah, particularly with regards to doctors that don't solely specialise in TRT.
Absolutely.
So if you're an endocrinologist and out of your patient population, only a tiny percentage of that is actually made up of people with low testosterone, you're also treating people with adrenal insufficiency or diabetes or whatever other endocrine disorder the person might present with. You don't have the time to delve into the nuances, so they will just read guidelines, throw people on Testogel and, move on to the next issue, particularly when testosterone, because it isn't directly life-threatening, although if it impacts someone's mental health significantly, you could argue that hypergonadism is theoretically life-threatening, but compared to something like type 1 diabetes or adrenal insufficiency, which, especially the latter, if not treated, is definitely immediately life-threatening, they're obviously going to direct their resources to understanding the latest available evidence and treatments available for those. So again, TRT just gets left behind and the nuances ignored. Patients typically suffer as a result, whereas if you have a doctor who day in, day out in practice is treating men with low testosterone, they stay up to date on the literature, but more importantly, they actually have real clinical experience with hundreds, if not thousands of patients. That's when things like more frequent injections providing significantly better results compared to every 2 weeks, that's when things like that come to fruition and you actually make those realizations.
Yeah, that's why you want to go to a specialist and not go, unfortunately, to the NHS. In the UK, there are very few GPs or endocrinologists or urologists in the UK who work within the NHS who have a really good understanding of how to treat this from what we've seen.
And it's understandable because when you think of how complex this one single treatment is, all the different variation in clinical presentations and reactions to treatment and all these different things we see day in and day out in clinic, it's somewhat unreasonable to expect a GP who has to know essentially everything about everything to have the time available to direct towards this.
Absolutely.
This is essentially why private care for TRT is becoming more and more popular, because realistically, I'm not trying to say that nobody will ever do well on treatment with the NHS or that it's not viable, because we're a private clinic, we obviously have our own biases in that regard, and I completely acknowledge that. But in the same respect, you just can't get that same level of treatment as you can in the private sector. It doesn't exist.
I mean, and this comes back nicely to the injection protocols or the administration protocols recommended by the pharmaceutical companies. If you're a pharmaceutical company and you're trying to sell Sustanon to an NHS GP, you're not going to say to them, it should be injected a few times a week, really, for optimal patient results, because we know that actually if you do once every 3 weeks, they're not going to feel that great. What they're going to try and do is say, you only have to get the patient in once every 3 to 4 weeks, inject them with this, let them off on their way. They don't have to mess around with a gel. That's absolutely great, and they'll feel brilliant. Same kind of thing with Nebido. There is an element of trying to sell it to the doctor as well from the pharmaceutical companies, and I'm sure that has an impact.
Yeah, absolutely. I would imagine it's one of the main reasons why essentially every single person that comes to us from the NHS on Nebido.
Or they're on Testosterone.
Yeah, exactly. Yeah, again, another
Failed normally with Testosterone.
expensive patented product, yeah.
Anyway, make sure you like the video and subscribe if you haven't already. Thanks a lot for listening, and I hope that was interesting. Again, if you've got any ideas of things that you'd like us to discuss, any questions, just pop them below, and we will speak to you soon.